Good morning, everyone. Hello, everyone from all around the world. Um, my name is Tran, and I'm one of the moderators for today's session, and it's my pleasure to introduce Dr. Aleksandra Babicheva, who is an assistant professor at the Hormel Institute at the University of Minnesota. Her research is focused on pulmonary vascular biology, and today she will present her article titled "Store-Operated Calcium Entry is involved in endothelium-to-mesenchymal transition in lung vascular endothelial cells. She is joined by Dr. Vineet Agrawal, who is an assistant professor of cardiovascular medicine from Vanderbilt University Medical Center. His research focuses on pulmonary hypertension and aims to understand risk factors for pathologic pulmonary vascular remodeling. He is a clinician and he will provide us with the clinical thoughts on Dr. Babicheva's amazing work. The moderators for today's session is Elaine Dye and myself. We invite all questions at the end of the session, as well as questions through the chat box throughout the session. Dr. Babicheva, please take it away.
Thank you very much for the warm introductions. Do you see my slides?
We saw it previously, and I think it's coming back up. Yes, it's on.
Back, okay. Right, thank you very much for this opportunity to present our recent work published. Today I'm going to highlight this research study. Store-operated calcium entry is involved in endothelium-to-mesenchymal transition in lung vascular endothelial cells, which we published last year in AGP Lung. So first of all, let me introduce just pulmonary and circulation, pulmonary and systemic circulation at the class. Most of you are familiar with these two systems, but I would like to highlight a few things that pulmonary circulation is a low resistance, low pressure, and high compliance system that allows the lungs to receive the entire cardiac output. So lung is the only organ which receives the entire cardiac output. So as you're familiar, we have pulmonary and systemic circulation working together to allow oxygenated blood to reach systemic organs and deoxygenated blood to return back to lungs. And as you see, the pressure between pulmonary and systemic circulation, it's very, very different. So as you see in right atrium, we have 2 millimeter mercury, while in left atrium we have 5. Right ventricle, when blood reach right ventricle, pressure typically is around 25 millimeter mercury, and then when it goes through pulmonary artery, it's decreasing to 14, and when it reaches pulmonary capillaries, it's about 12, and starting to decrease when it's going back to heart through pulmonary vein into left atrium. And as everybody knows, in left ventricle, we have 120 around millimeter mercury. This systemic or arterial blood pressure, which is probably everybody is familiar. And whereas blood pressure is higher than 120, so that's we can see systemic hypertension. But what is pulmonary hypertension? Pulmonary hypertension is a fatal disease with no cure, where pulmonary arterial pressure becomes more than 20 millimeter mercury. Again, normal mean pulmonary arterial pressure around 14 millimeter mercury. When it increases more than 20, that's recent updates from World Congress on Pulmonary Hypertension. So now threshold is 20 millimeter mercury. And this schematic actually better explain differences in blood pressure between systemic circulation and pulmonary circulation. As you see, in systemic circulation, blood pressure from systolic around 120 and diastolic is 0, and then it starts to decrease when blood travels from large artery to capillary, small artery, capillaries, and vein. And as you see in right ventricle, it's much, much lower pressure, around 20 or 15, 20, and that started to decrease from that level. So what is cause pulmonary arterial pressure increase in pulmonary hypertension patients? So there we have got a consensus about 4 major causes of elevated pulmonary arterial pressure. And pulmonary arterial pressure is increased due to elevated pulmonary vascular resistance. So this is Puazure law, apologize for my French, which means that pulmonary arterial pressure is depends on cardiac output in pulmonary vascular resistance. While in pulmonary hypertension patients, cardiac output typically stable until the very late stages of the disease when it starts to decline, but that's a determinator of mortality. So most of the pulmonary arterial pressure depends on pulmonary vascular resistance. So the higher pulmonary vascular resistance, the higher pulmonary arterial pressure. Pulmonary vascular resistance, in turn, inversely proportional to intraluminal radius. So as you see, intraluminal radius and a power of 4. So what it means? So it means that even small decrease in intraluminal radius cause significant increase in pulmonary vascular resistance, and it affects pulmonary arterial pressure. So what we know so far that these major causes result in elevated pulmonary arterial pressure. So it could be caused by sustained pulmonary vasoconstrictions. That's mainly due to pulmonary arterial smooth muscle contraction, pulmonary vascular remodeling. That's due to increased or hyperproliferative abilities of all cells in pulmonary artery, including fibroblasts, smooth muscle cells, and endothelial cell layers. And also in situ thrombosis due to fibrotic loss, where participating fibrogen and fibrin, in arterial wall stiffness when vessels cannot dilate or be flexible due to extracellular matrix production, excessive ECM production. So what we know so far that the first 2 causes are heavily dependent on calcium signaling. Calcium is very important for pulmonary vasoconstriction and cell proliferation, which is involved in pulmonary vascular remodeling.